Hi, good afternoon, everyone. It's John Snyder, 12:30 on a Thursday. Welcome to another edition of Newton-Wellesley Medical Group, Lunch and Learn. We're happy to be here today and also happy to have the team from New England Life Care to teach us and to tell us about the services they have to offer us. Also talking about consideration of VAD placement in the home, but I know they're going to be talking about other great services that they can offer us as practicing physicians, so we're excited to have them here. Next slide, if we can just want to tease the upcoming Lunch and Learns. We have a really good schedule, actually all the way through March, I think, we're booked now, even into April. Next week, we'll be hearing about the multidisciplinary management of IBD in children and adolescents with our pediatric GI team, and they do an excellent job. I'm excited for that talk. And then coming up, identifying common skin rashes. And then our chair of medicine, Dr. Friedman, going to be talking about viral hepatitis 2021. Next slide. Couple of physician wellness programs I always like to tease. Make sure you guys know Thursday nights there is virtual meditation, which is drop-in. That should be in your calendar. If you're having trouble accessing that, please email myself or Audrey, and we'll get that on you. And then next slide talks about our physician care concierge program. Again, a great program. It is free to us, and all you have to do is register with the code NWH. And essentially, it is an Angie's List for any service that you could possibly want or possibly need in your area, from anything from planning parties to fixing up your house or moving or anything to that. They do supply names and numbers of local professionals in your area that can help you with any service you can imagine, from removing snow to walking your dog. So that is available to you. We want people to make sure that they are using that as well. And then next slide, I will stop talking and leave it over to the professionals of New England Life Care. Thank you.
Thank you very much, John. My name is Pam Fine. I'm the Director of Partnership Development for New England Life Care, responsible for the Mass General Brigham system. And we're delighted to be here today. I'm joined by our expert vascular access leader from New England Life Care, Janet Henry. Wave Janet so everybody can see you. She is going to be providing the educational component of today's session. And we're also joined by Megan LaJoy, who is our full-time on-site nurse liaison at Newton-Wellesley. She is predominantly responsible for working with case management and any of the outpatient providers who might have patient needs or needs for their patients related to infusion and nutrition. New England Life Care is a not-for-profit hospital services cooperative. We're a 501(e) structure, and that means we are wholly owned and managed by our member hospitals and fully directed by our member hospitals. We have a board of 15 members, 5 of whom come from the Mass General Brigham system. We have a charitable mission, and that is to treat all patients and care for them in their homes, regardless of their ability to pay. And we have a vision that is intended for us to always be continuously changing and adapting our capabilities to the needs of our members so that we can help you transform the care continuum. Without further ado, I'm going to turn, actually one more slide. I'm going to just show you an overview of the various service lines that New England Life Care provides to all of our members, so many of which Newton-Wellesley is in the aggregate is very familiar with. And now I'm going to turn it over to Janet Henry, who is going to cover the vascular access portion of our presentation and talk with you a little bit about what are the provider considerations for patients that might need.
And before you turn it over, can you turn it into slide mode so it's just a little bigger?
Oh, absolutely. Yes,
that'd be great.
Do that for sure.
Sorry, you won't hear from me again. Thanks.
That's okay. I'm gonna move this thing up here. There we go. Is that better?
So I lied, you're gonna hear from me again. So that is better, but if you go to display settings up there and just change it to, get it off this preview mode, you'll get regular. Next one over, yeah.
Yeah, oh, thank you. And what am I just want to swap there.
Mm-hmm.
All right. Ah, thank you. I just learned something new. It's always good. And Janet, why don't you take it away? Thank you. I'm going to mute myself.
Okay, hi everybody. Really happy to be here too, and I hope you gained something from this and a little background into our new services that we're offering with New England Life Care. And basically, we have been placing midlines for quite some time, but back in April of 2020, we decided to go full time into placing PICs and midlines. And I think that this is actually a great segue for the business line that we do with Infusion. And then of course, with the whole COVID thing, this really fit nicely in with being able to work with the member hospitals and working to either prevent patients from going into the hospital or intercepting them so that they could stay home, or the other way around, trying to move patients out so that they could free up beds, because we know that there's been a huge crunch for that reason. And we have found great value to our members for that reason. And we've also found that there's tremendous interest in sort of the periphery of that, so the outpatient settings, clinics and things. So we are definitely, 100% on board with providing this service. And so that being said, what New England Life Care has done is created these guidelines that encompasses all our medications on formulary. And what that means is it really determines what appropriate access would make sense for the type of therapy that you are instilling into the patient. And those guidelines are usually based on INS guidelines, which takes into consideration the pH of the medication, the osmolarity of the medication, pH being anything less than 5, greater than 9, would require like a central line versus something that can go in peripherally. And then the osmolarity being over 900, of course, would require central as well. So we do place a fair share of midlines. So I don't want to always just speak to PIC lines, because realize that midlines do have a place. And we have found they are actually well tolerated. We do place them quite the same way as we do a PIC, and I'll get into that a little bit more. So the other thing too is that in addition to our formulary of medications that we have, I want to just kind of speak to a little bit of, like, say, for example, like Tpn therapy, because that's not technically on our list per se, but we do a fair amount of home starts for Tpn. And the thing is that we do have some certain criteria for that as well. And we have a full staff of dietitians that work with the practitioners, and they will develop a treatment plan formulary for the patient's Tpn, something that we can actually start at home, looking at their lab work, and then establishing access to be able to actually avoid that hospitalization. And we've been doing this successfully for quite some time. So I just wanted to kind of throw in that therapy, because sometimes you don't often think of that, because sometimes it's the knee-jerk reaction is to hospitalize the patient to get that started. And it isn't always necessary. We have been able to do it safely. And
that's a great, Janet, I just want to jump in and say that's a great point. And over the course of the last 10 months during COVID, this has been something that our GI referral sources and physicians have been requesting a significant amount of. It's really a big increase.
Right. Thanks, Pam. And that's very true. We do cover Maine, New Hampshire, Massachusetts, and now even into Vermont And we've had a tremendous uptick for the need of home starts for TPN for that reason. But the next thing I wanted to discuss is that as far as when a patient needs to be established with infusion and we're going to be placing the line, we do have some criteria that we need to meet as well. And of course, that first criteria involves the orders. The orders need to be complete. And Pam does have a copy of, a blank order form that I don't think it's on the presentation, but the blank order form would spell out exactly what we need. And it's really not complicated, depending on what it is that we need as far as, is it going to be a midline or a PICC line? Those two choices. And the lidocaine, absolutely, we are going to anesthetize the patient. Don't think it's fair to not do that. So we need to have that checked off. And then if we're going to do a PICC line, we do ask that you include the X-ray. We do 3CG technology for confirming tip placement for PICC lines in the home, but we also have the chest X-ray backup plan because, and I'll go over this list here of pre-questions that help understand this, because sometimes there are situations that might arise in the home that we need to have the X-ray in lieu of being able to verify them with the 3CG. And we have a contract with a mobile X-ray company to be able to do that. So all I simply need is the practitioner to just check the box, just so that we have that in place, and it makes an easy phone call for us to make if we have to essentially pull that card. And so once the orders are in place and we've got them completed and everything looks good there, then we're going to move on to the next step with pre-screening the patient. And so what you see on the screen are basically the questions that we are going to call the patient. If we can't reach the patient or somebody that actually knows the patient well, sometimes we can derive some of this stuff from their clinical record, but most of the time it's going to come straight from the patient. And it's pretty simple to simply ask them about access to the residence. And I'm going to tell you that's important, and it's because of the chest X-ray. The equipment that they drag up the stairs is 100 pounds. So they really want to know if they have to go up to the third floor because the patient is immobile. And we do a fair share of patients who are not mobile and they're bedridden or they're disabled, or, they have tight squeezes getting up into the stairwells because we have old apartment homes. So that's a really critical question to ask. I know it's non-clinical, but it really matters, at least for the person who's doing the X-ray. And then of course we want to know about the pets. Oftentimes patients have pets. We got to make sure they're put away because we do this under a sterile procedure. Obviously, is the patient mobile, the patient must lie flat in a bed. So if you know, have you seen a PICC line or mid placed in the hospital setting, they must be in a bed. They must be laying pretty flat if at all possible. And then of course, then there's the clinical questions. We need to know if they've had a history of having a port in the past, or if they even currently have one, because if they do, it may matter because you've got wires that are actually extending into the vasculature. So we need to know that's there. Surgery to their shoulder that might cause some impingement problems, radiation, vascular surgeries to the chest area, filters, dialysis, that's a biggie. Somebody who's pretty debilitated in receiving dialysis, if they have fistulas and we have to avoid the arms, or if they have a dialysis catheter in their chest, again, that dictates a lot, whether or not we can place lines. And then, lymph node dissections, mastectomies, again, avoiding certain extremities for line placement. Does the patient have a pacemaker? Do they have AFib? Those are two key questions that we have to ask regarding the use of the 3CG, because the 3CG is based off of the EKG rhythm, and we are looking for a P wave to be able to have our trigger for our PICC tip placement. Patients who have pacemakers and have AFib will not have those. So we are not able to use the 3CG, and this is where the chest X-ray comes in. So this is important for us to be able to determine which direction we need to go. And then of course we need to know if they're going to have some bleeding tendencies. And so we put the list of things that they may be potentially on that flags us, because some patients just think if they're on Coumadin or Eliquis, something like that, that's all we need to know. But we know that there are other things that can cause bleeding, excessive bleeding. So we need to know that and be armed with that information. And then the last thing, of course, is do they have an allergy to lidocaine? Now, I will tell you that's pretty rare, but I have encountered it once where somebody did actually have an allergy to lidocaine. And I felt really bad for that patient because unfortunately, you know, trying to do this procedure without it is not comfortable for anybody. Even, I mean, because we have to use the Seldinger technique, which is it's essentially like an expander. So you know that can be extremely uncomfortable. All right, so next slide. We did, and this might actually help you folks with setting up patients for any vascular access and infusion needs. What we did was we created a patient, this is a patient information sheet, but we also created a frequently asked question form, which I don't believe is really on here. But as far as when you're educating and setting up the patient for the service, we think or thought that it would be best if you were able to provide them with some literature to be able to help them better understand, and has, you know, some pictures. People are, you know, visual, and they like to see, you know, what they're getting into. And so we created these documents that have been valuable to patients to help sort of allay their fears of having these lines placed, because it's a very unusual setting to have this done in their home. So I think that, you know, by having them understand what the expectations will be, and, you know, and what the difference is between the type of lines that we're, you know, going to be doing or what they have, the doctor has ordered for them, helps them understand why. So if you go to the next slide. So here's an example of what it looks like. It's really very much what you see in the hospital setting, in that we do use a maximum barrier procedure. So maximum barrier meaning you see that the specialist has got the hat on, you know, all the PPE, gown, gloves, and we actually drape the patient entirely. And because you can imagine when you go into some of these homes, they're not always the cleanest. So we definitely take a huge precaution to be sure that, you know, we're being careful about ensuring that this is as sterile as possible. And then, you know, the procedure itself probably takes all of like maybe 45 minutes, an hour, depending on whether or not there's any issues, but generally speaking. And we do a guided ultrasound. And I did pull out my machine. I don't know if you can see this, but it's nice. It's a little portable one. And I also dug out my Sherlock, which is the navigation machine. If you haven't seen this, it's very lightweight, it's very small, and you just put it right underneath the patient's chin. And then it helps to navigate the catheter as it's going south. You can see it on the ultrasound screen. And so once we have our tip confirmation, we have our P-wave trigger, we're able to capture the image, and then we can provide it to as documentation that the line is in place. And then after the line is placed, we have a visual as to what the patient can expect for addressing to that site. You can go to the next slide, I think. So this is just a picture of the three of us that are qualified to place lines at Newton-Wellesley Care. And the next screen, I think it just gives, yeah, so it, I don't know if Pam, you want to speak to this, but I think that as far as our guidelines, what I want to encourage you to do is that obviously we try to take the guesswork out of this, you know, as far as, well, what are you going to choose, midline or PIC? And we have these guidelines, and they are just guidelines because we have had exceptions to the rule. but we look at the patient's situation. There's a whole gamut of things that we're looking at, obviously the length of therapy, the drug that's going to be infused, how often it's going to be done, is it going to be put on a pump? So there's a lot of other factors that we look at in terms of, making the best decision for the patient in terms of what type of access. So I recommend that if you have a case and you're not sure, have a conversation with us, and we can talk about what makes sense.
Right. Excellent. Excellent, Janice. And I'm going to say that this is, I think, the time we would like to invite questions, if there are some. I have up on the screen here really two very critical and very important key resources for Newton-Wellesley, for the Newton-Wellesley community. And one is our Centralized Infusion Resource Center service. And that really is a single communication. And you can send a request, even a question. If you're looking to find out how to contact Janet, you want to talk to her, they can help you with that too. But the purpose of the Infusion Resource Center really is to provide a centralized resource for all things IV and nutrition related for patients at home. And they manage the referral process and the capture and collection of any appropriate clinical documentation that the IV company or the VNA might need. And following that, the services placement of a referral, that's when our superstar on-site liaison nurse, Megan LaJoy, and her cell phone and beeper are on the slide here. She's easy to access, and she's a wonderful resource for consulting on anything. It could be vascular, it could be just questions about providing services at home, that kind of thing. So I'll be quiet and then open this up, I guess, for questions. John?
Yeah, hi. So thanks for that. So one of the things I think might be helpful for folks on the phone is I'll just give you a clinical scenario and tell us the best way to manage it, because it's something that typically comes up in our office. So let's say we see a patient who has a cellulitis and needs IV treatment of ceftriaxone, not an extensive line, or needs 4 weeks of intravenous antibiotics for, say, an endocarditis. And we're going to treat them as an outpatient, and we're going to have to start. So I guess my first two questions is, I think I know the answer to this, that you can't do the referral straight through Epic. You have to pick up the phone or fill out the paper. And number two is, what's the best way for the PCP to kind of initiate this? And remember that, and I know you know this, but the easier the better from a PCP office point of view.
Right. And I'm going to start with the information that you don't have to initially fill out a form or call anybody per se. You could send an MRN, a patient name and a date of birth. We just need 2 identifiers to the nwhirc@partners.org. They will initiate the referral, notify Megan that there is a new patient, potential new patient need, and she will then circle back directly with the practice. Megan, feel free to jump in here if you want to add anything there. There is, as you know, John, unfortunately, we do not have an order that's yet built into Epic, which is something we'd love to be able to work on as a project sometime this year. But it does require a paper order or orders, perhaps in the case of a line placement and a antibiotic. So did that answer the question?
Yeah, that does. So we can just email NWHIRC,
Yes.
excuse me, and then go ahead and then you'd contact us and we'd put in any orders that you need to be put in for the antibiotics, et cetera.
Exactly.
And another question that comes up a lot is patients who leave the hospital with PICs in place or central lines in place. If you didn't place them, will you care for them, check on them, and pull them when needed?
Go ahead.
Yes, if we're providing the infusion care pharmaceutically and everything, yes.
So when it's done, so So if I, again, just to use the same example of the endocarditis, if after 4 weeks, once you place the PICC line, will you or someone in your team be going out to hang the antibiotic once a day? Or would that be a total separate service?
So the intent is for patients to learn how to do their own therapy. There could be, depending on payer issues, it could dictate that a VNA be pulled in because we can't bill for the nursing. So there's kind of a couple of caveats to that.
Yeah.
Sure.
Yeah, there are varying scenarios in terms of putting the whole plan together for the patient at home. And that is where Megan's expertise comes into play.
Right.
She will work with the whole insurance piece, communicate with the patient, explain it to them, and make the determination whether or not a VNA is necessary based upon the patient's needs. The IRC will make the referrals for that for you, get that put in place, and then Megan will coordinate directly with whoever liaises for the VNA that will be caring for the patient. So it sometimes it looks like magic. There's a lot of work that goes into it, but comes out great on the other side.
Terrific. Two more quick questions because I don't see anybody chiming in, but one, and you can answer these in a row. One is, do you take care of the pediatric population? We have some family docs on this call. And then, well, that's the first question.
Yes,
Okay.
We do. Yes.
Okay. So, and then the second is sometimes we run into problems with certain services and certain insurance companies, such as Mass Health or Medicare. Is there one that we would be a non-starter for this service?
Right now, Medicare does not reimburse for line placements. We do take lots of patients home on antibiotics and hydration and IV Lasix and all kinds of different medications. Unfortunately, it doesn't cover the vascular access placement in the home, but we do typically make arrangements with IR for those patients to come in and have the appropriate access placed. Mass Health, we take Mass Health also, and Mass Health, unfortunately, again, doesn't reimburse for the placement at home. At this point in time, they are considering, they're expanding, I think, their purview on the world, and so maybe they will in the not too distant future.
Yeah, and just to segue off that, we have had, it's not often, but we have had some patients who are Medicare where it isn't covered have been willing to self-pay for it. So it does happen.
Sure. All right. Well, thanks. We have this email there, and we'll put this talk up online, and it's available for everyone. I wanted folks also to know next week is a special combined surgical and medical grand rounds, and that grand rounds is going to be starting at 7:30, and it's going to be given by Dr. Anthony Mayo, who of more famous things is the husband of Denise Mayo, but also we'll be talking about toward a racially just workplace. So a really interesting topic. So that's going to be Wednesday at 7:30. And of course, we'll be back next week for our lunch and learn. Everybody have a nice weekend and a long weekend for most. So thanks for joining and thanks for coming. And thanks to New England Life Care. Hopefully we can continue to send you some business. Thanks so much.
Thank you very much. Bye-bye.